All right, guys, we're back and we're going to talk about how we are going to start treating the acute coronary syndrome. And once we identify that we've actually got one, how do we fix it? How do we go? Okay, how do we translate that into what we're going to do? Okay, and actually, I went a little bit longer than I was planning on the last video. So the good news is hey, this will be shorter. All right, so rapidly recognize it with sudden myocardial ischemia. That is the number one thing. Get that 12 lead, get that 12 lead, get that 12 lead, okay? But as we're listening to these guys, okay, while we're getting those stickers on, matter of fact, we can talk and put stickers on at the same time, okay? So listen to what they're telling you, the story, the risk factors, and what their EKG says. That's our immediate evaluation of that, okay? So listen to what they say. If their story matches, no matter what this guy says down here, if the story's matching and they've got significant risk factors, absolutely we need to think of it as cardiac chest pain until proven otherwise. So you can have the classic angina, the Levine sign, the holding on to their chest, their gets worse on exertion. They could have those classic anginal chest pains, not relieved by rest, okay? You can have atypical. I got pain up in my chest, my jaw, my back, going down into the arms. I'm nauseated. I'm throwing up for some unknown reason. And again, anginal equivalence, okay? Shortness of breath along with that. So all of these things are involved in the assessment. Again, anginal chest pain, central anterior chest. It's usually a pressure sensation, a fullness, tightness, crushing, and it radiates into the arms, neck, or back, okay? So these are classic, the typical chest pain, okay? But your atypicals, all right? Again, pleuritic features, it's unilateral, described as sharp or stabbing, includes epigastric discomfort, and usually, folks, the ladies present atypically. Back pain is the number one, right between the shoulder blades. They're going to say, I just can't, it hurts even worse. I'm telling you guys, this is a classic symptom, especially with the ladies, okay? Diabetics, sugar goes high, okay? They're having a lot of shortness of breath. They can't explain it. They feel their heart racing. They have generalized weakness. Wow, I got all those symptoms. I don't know. Well, who knows? So, again, anginal equivalents. Okay, again, all of these things are equivalents. They passed out. They feel like they're going to pass out. Their sugar goes high, and they can't explain why their sugar is going high. You know what? They hadn't had nothing to eat today, and their sugar is remaining above 300, and they can't get it down. A good reason to definitely start taking a look at. And anytime I have a diabetic who is having a sugar problem with their sugar going high and they can't control it, 12 lead. You'll be surprised how many that you catch. Now, I've often said that these three groups should come with pre-installed post. If you've got 2 of the 3, you should probably think about having post inserted into you. And if you got all 3, it should be surgically grafted in. Okay? Long and the short of it is that, yeah, elderly, females, diabetics, guys, run a 12 lead, okay? Especially when they have an atypical presentation. I just feel bad. Put some stickers on their chest, okay? Trust me on this. You're probably going to find more than you bargained for, okay? Try to find out the exact time that these things started, and again, the types of symptoms that they're having. You definitely want to do that, all right? Again, the 3 subsets of EKG treatment is the non-diagnostic. In other words, we don't see anything, no ST wave abnormalities at all, okay? There's no T wave inversions. There's no ST segment problems. Anytime that I have ischemia problems, we're not really sure they have ST depression or T wave inversion. Those are the ones that we consider they're suspect. But the ones that we definitely look out for is the ones that we know are getting injured, which is your ST elevation MIs, okay? So again, like we said before, that we kind of group them into 3 silos. They don't have anything, doesn't mean that they're usually not a candidate for reperfusion therapy immediately, okay? Versus the ST depressions, again, this is a non-diagnostic EKG. Again, looks good. We're going to run the blood work, and if the blood work comes back and it's normal, we'll probably follow it up 4 hours later with some more blood work, and if those are normal, we usually send these folks home to follow up with a cardiologist, okay? Now, if we got ischemia, I mean, again, it doesn't rule out an MI, but they're not really a candidate for reperfusion therapy right then and there. So if I click on this guy, and let's see here. Do I have any elevations? Nope, but I got depressions. Nope. All right. Depressions. So I've got depressions in significant places here, but really I don't really. That's kind of a. But if I even come over to here, if I had to make a bet, I'd say that one's kind of suspect. But again, do I need to rush this person to the cath lab? I would say not just yet, okay? Now, again, if I definitely have evidence of cardiac, the myocardial injury, again, 2 or more contiguous leads, 1 millimeter of elevation, yep, good enough for me, folks. Yep, definitely good enough for me. This one's, again, the baseline is the TP segment, which is way down here. Okay, that's one box. All right. Do I have reciprocal changes? Right there. Depressions right there. Oh, well, wait a minute. Whoa, we got some major issues going on right there. So, yeah, this guy is definitely going to the cath lab. All right. Go along with the story of this. Okay. Go along with the story. If it's sounding like it, in other words, they're telling you, hey, I feel like I'm going to die. They got that crushing cerebral chest pain, and they got just a little bit of elevation. Assume that it's the real thing until proven otherwise. Bundle branch block. So let's back it up. When I first started teaching 12 leads, it was if they've got a bundle branch block, guess what? If it's a left bundle branch block, it is definitely, they are presumed a candidate for reperfusion therapy. And not so much anymore, okay? This is where it helps to have an old EKG. Of course, all of our patients carry a copy of their EKG along with them. It's amazing how they do or don't. But it can mask or mimic acute EKG changes. One of the biggest problems with it is it usually has a T wave that's up here, and therefore it's really hard to tell whether this is an elevated T wave or is that the SVT. It's really hard to tell. So a lot of the times now they're saying with a bundle branch block, no, yeah, they've got a bundle branch block, but do we really need to take them to the cath lab right here, right now? And most of the time that answer is usually no. But remember when I said that usually if you've got damage going on to a certain area, notice how that would block this through, and then again, it would cause the signals to have to shoot around where the bundle branch block is, okay? And the problem with doing that is, again, is this a fresh injury that's causing this problem, or is this person already had this and the damage is already done? Do I need to get them into the cath lab right here, right now? One of the things I always do with my bundle branches, number one, listen to their story. Okay. Number two, I fax it ahead. The simple, long, and the short. Fax it ahead. All right. You need to let the doc know that you've got something that's of significance. So again, we've talked about how to identify it, 120 milliseconds or more, which is the wide QRS. Again, and they're usually a supraventricular rhythm. Okay. They are a supraventricular rhythm 99% of the time, okay? Supraventricular, even if it's AFib, A-flutter, supraventricular, okay? Now, again, the bundle branch, it might be low. Again, if the story and the risk factors are there, send it ahead and tell the doc, hey, take a look at this one, tell me what you think, all right? So again, this guy right here, I'm looking at this, I'm going, well, wait a minute, do I have elevation here? Yeah, but I have a bundle branch block, gang. If I have a bundle branch block, I can't go off of that, okay? I really cannot, especially if it's a left bundle, which this guy is a left bundle branch block, right? So again, he's got a huge amount of hypertrophy. Um, I'm kind of in a debate here about what. So again, I'm going to send this ahead to my doctor and say, hey, take a look at this for me, okay? By the way, this guy has some significant um, progression in is in the Q wave here as far as the deepness goes. He actually meets a certain criteria. Um, so again, but I would call ahead and let my doctor know and say, hey, you need to take a good look at this. All right. Let's see here. Here's the point, though, is that a lot of times with bundle branch blocks, um, they end up with MI or ST depressions. Most of the time, these are rushed to the cath lab, and they didn't really need to go. But with our bundle branch blocks, there's a lot of data that says, hey, if they've got anterior MI with ST elevation or a bundle branch block, there's usually a significant life save by doing that. But again, let the cardiologist take a look at this, and I can't stress that one enough. Call ahead and make sure that they take a good look. All right. So again, immediate treatments, general treatments that we do, and then we lump them into one of those three categories: ST elevation depression, ST elevation, ST depression or T wave inversion, or the non-diagnostic. Okay. Again, these guys probably not going to go to the cath lab. Okay, no cath lab for them. These guys, I'm hoping that you don't even stop in the emergency room and go straight to the cath lab. All right, so guys, when we're talking about, we want to put them into one of those three silos, okay? But we got to get our 12 lead. We got to start evaluating the patient, all right? We really do need to do that, all right? And if we've got ST elevation, again, that kind of ups the ante a little bit. We need to get them to a cath lab as soon as possible. All right, that's going to end it for this video. We're going to see you on the next one.